Good morning. The topic of today is managing failed airway. I am Dr. P. Nagalakshmi, Professor, Department of Anesthesia from Pondicherry. And why is this important is a failed airway is important because how do we define failed airway is a failure to maintain adequate alveolar oxygenation in a patient by face mask, supraglottic airway or an endotracheal intubation despite optimal attempts at these techniques. This can result in a cannot intubate, cannot oxygenate situation. This is otherwise called as the complete ventilatory failure also. Now there are three components of failed airway. It can either be a failed face mask oxygenation, which is defined as a face mask oxygenation which is considered unsuccessful after additional maneuvers which has been attempted, which includes a two-handed maneuver or a 2% technique or insertion of adjuncts such as oropharyngeal or nasopharyngeal airways. The second component is the failed supraglottic airway, where oxygenation via an supraglottic airway is considered unsuccessful after multiple attempts with different types and different sizes of devices, which can either be an iGel, ProSeal or a Bosca mask airway. And the third component is the failed endotracheal intubation, which can be considered unsuccessful when a maximum of 3 optimized intubation attempts have failed in securing the airway access, plus one more by a more experienced senior clinician. So we always call a failed airway when we fail an endotracheal intubation, but we must also identify the failed face mask ventilation and failed supraglottic airway insertion. So the prime aim of airway maintenance is to maintain the oxygenation rather than intubation. So oxygenation is considered easy when there is an easy bag and mask ventilation with basic airway maneuvers. There is some difficulty. Then we manage the airway with some oropharyngeal or nasopharyngeal airway. If it is difficult, we restore to two-hand bag and mask ventilation or rescue CAICO techniques such as supraglottic airway devices. And it becomes impossible when there is a poor bag and mask ventilation, unsuccessful ventilation with supraglottic airway devices where a front of neck access is needed. And intubation becomes easy when a standard laryngoscope is used and it gives a Cormack-Lehane grading of 1 or 2 and the ET tube passes easily. Then if the view is between 3 and 4 or a video laryngoscope is needed, then we call it as a difficult airway. And it becomes a difficult airway when with video laryngoscopy there is an anteriorly placed larynx and partial view of vocal cords only is seen and there is a difficulty in advancing the ET tube through the cords. It becomes impossible when there is no view of glottis with even video laryngoscope or fiber optic intubation is needed, and even if this fails, then we land up in a cannot intubate, cannot oxygen situation and we restore to the front of neck access. So why are we worried about the failed airway situation? So what is the problem statement? There are a lot of studies and retrospective multicenter analysis which has been happening across the world which says that this is a life-threatening outcome which may result in the death of the patient. So this is a 4th national audit program conducted in the UK between 2008 and 2009. This says that the serious airway events requiring failed airway is a rare but adverse event but can result in the life-threatening situation. So this similar studies have been conducted in Japan, in the Danish anesthesia database and in the Netherlands, where we have seen a lot of CAICO situations happening and the patient is in, it causes mortality of the patient. So CAICO can result in, that is cannot intubate, cannot oxygenate, can result in hypoxia, brain damage, cardiac arrest and death, and has been reported to cause in about 25% of the anesthesia related deaths. So in a review of malpractice claims related to difficult endotracheal intubation from anesthesia close claim projects database, CAICO has occurred in about